Let's move on to our first set of diseases, which is the eyelid disorders. So now, first question here, you can see an image. Okay, so meanwhile, as we deal with each question, I will also mention about how to approach these questions. Okay, how to approach or read an image. So first, what you need to identify is what type of a photograph is it. Is it an anterior segment photograph? Is it a slit lamp photograph? Is it a retina fundus image, or is it an investigation in the form of fundus fluorescent angiography, and so on. So first and foremost is for you to identify whether what kind of an image that's. So this is clearly an image of the anterior segment, okay, or I would say slit lamp image. Okay, what you can see here are the eyelashes, okay, the eyelid. This is cornea, iris, etc. So our area of interest here is this particular structure, which is unusual compared to the others. So what is this? This is actually a misdirected lash, eyelash, okay, and it is directed towards the cornea, unlike the others which are directed outwards. Can you see this? Okay, so this is the major point of this image, and this is referred to as trichiasis. Okay, so inward misdirection of eyelash or lashes, it could be single or multiple, which irritate the cornea and or the conjunctiva. Okay, so what I am trying to say is this lash, because it is turned inward, that results in abnormal irritation and troubling of the cornea, and can even cause abrasions over period of time because of frequent blinking. Okay, and it causes punctate epithelial erosions, or can even cause frank ulcer when that is superadded with an infection. Okay, the epithelium once debrided is no longer protective to the underlying stroma, correct? So the organisms can come and get lodged in that and multiply and proliferate, and that is what results as a corneal ulcer. When associated with an entropion, it's called as pseudotrichiasis. So it is important to understand trichiasis from pseudotrichiasis. Here, all the other lashes are in the right direction, and the lid margin, okay, this is the lid margin, which is very nicely well opposed with the bulbar conjunctiva, which is the white part of the eye. Okay, in case of entropion, what happens? This lid margin itself is interned. Okay, so this is the eye. Okay, and the lid margin itself is in turn leading to the lashes, though they are pointed in the naturally correct direction, they are themselves not misaligned. But because the entire lid margin is interned, that results in trichiasis like picture, or what we call as pseudotrichiasis. Now, there is another condition called as dystrichiasis. What is this dystrichiasis? This is nothing but extra row of lashes. So what happens? Let us say this is the lid margin. Okay, the lid. So here is the cornea. So I'm just drawing the lid, the lower lid, as a bigger, thicker square. You divide it into two parts. This is the anterior lid margin, posterior lid margin. Understood? So this anterior lid margin is where the lashes grow. Is that clear? Whereas posterior lid margin has the openings for the meibomian gland. Okay, this meibomian gland is what produces the sebum that is important for the lipid layer of the tear film, correct? Sometimes what happens, this is abnormally differentiated. Okay, and instead of this forming a sebaceous unit, it forms a pilosebaceous unit, and there will be another hair growing. So an added row of lashes growing behind the normal row of lashes is called as dystichiasis. So trichiasis, pseudotrichiasis and dystichiasis must be differentiated between each other. Is that clear? Right. Before we move on to the next one, so we discussed about entropion, right? So I'll just touch upon entropion a little bit. In elderly, it is called as involutional. Okay, whereas it can be because of cicatrical, following some injury or burns, it can become cicatrical due to formation of scarring. Okay, then it can be congenital. This is like burns, trauma, etc. Whereas congenital is because of abnormal development of the muscles on that upper or lower lip. Okay, so imagine if this entropion, okay, if it is going to cause trichiasis, okay, what else can it cause? I mean, this is not trichiasis, trichiasis like image. Okay, it can also cause corneal abrasions and that results in frequent watering. Understood? So these are some of the presenting features of entropion that you must remember. And treatment is repositioning of the lid. It has a lot of named procedures. Let us not get into the details of that. Smith's procedure and Bick's procedure, Quicker's procedure. So many names are there. There is all in too much detail. But understand that you need to reposition the lid, making sure it is facing outwards. Is that clear? So now let's move on to the next picture. Can you see this? This from the graying of the eyebrows and everything. See, as far as an image goes, you should pick up clues from every small detail in that. Okay. Now this may look very simple, but sometimes you need to justify your, because at that time of exam, you don't have anybody to justify or to support your guessing of the answer. So you need to pick up more and more clues from each and every image in order to support your probable diagnosis, and then they may ask you a second step question which can be answered based on the first step. So here we all know that this is looking abnormal, that is the lid margin is everted, correct, and from the graying of the eyelashes and everything, and see the patient seems to have cataract, okay, graying of eyelashes, suggesting of an old man, right? So old man or an old woman having eversion of the lid with exposure of the palpebral conjunctiva. Palpebral conjunctiva. So that is called as ectropion. So ectropion is outward turning of the eyelid margin due to whatever reasons. Like we had a classification here. Again, ectropion can be senile or involutional, can be cicatrical. It can also be paralytic. Why paralytic? Because the seventh nerve is responsible for the supplying of the orbicularis oculi. Am I right? So orbicularis oculi, once it is gone, it is not going to give its usual tone to the muscles around the eye, correct? So what happens, because of lack of support from the outer aspect or the muscle which supplies the or which causes the closure of the eyelids, now there is nothing to support the eye from outside. Orbicularis oculi is gone. So because of that, this eyelid margin tends to fall outwards, and that results in paralytic ectropion. Okay, there is something called as a mechanical ectropion. what happens is if there is a swelling or huge mass or a sebaceous cyst kind of a thing that is arising from the lower lid skin, it will pull out the lid, okay, and make the lid margin turn outwards. So that is called as mechanical ectropion. Is it clear? So these are all the several causes of ectropion, and ectropion again mainly in the involutional type is because of lid laxity. So as a person ages, the skin and the tone of the muscles underlying the skin, they become more lax. When that happens, it is not able to keep the tone proper, and hence the lid margin tends to either fold inward, which results in entropion, or fold outward, okay, fall outward, and that results in ectropion. So what we need to do is we need to make it more taut, and that is by excising a small portion of the skin, and the procedure is called as Kunt-Szymanowski procedure, etc., etc. So lid shortening procedures are there. So what has happened? The lid margin has become longer. So you need to make it taut and firm by taking out the excess skin and the muscle and resuturing it back. So these are some of the points of ectropion. So here we are seeing involutional or senile ectropion. It is an age-related condition affecting the lower lid. It's the most common form, maybe unilateral or bilateral. So it can happen like we discussed in the previous session. It can be a sequential thing also. First one eye, then the other eye, or can involve both eyes to different severities. Due to the excessive horizontal ideal length with the weakness of the preseptal part of orbicularis, laxity of the medial canthal tendon is marked. So here, what I'm trying to say is there is a tendon which attaches the skin to this bone that is called as medial canthal tendon. Same way, lateral canthal tendon. And here is the orbicularis oculi. So 1, 2, 3. All these three factors, okay, 1, 2, and 3. When they become weak, the skin becomes saggy and tends to fold outwards. Now, what is the problem if it folds outward? At least in inward, we know that it will go and rub the cornea, let it fall outward. Now, what is the problem? See, falling outward means the skin which is supporting the storage of tears, the lacrimal secretions, it is now reduced, and moreover, always this patient will have pouring out of tears and watering complaints. So it is very irritating and annoying for the patient when he constantly has this tears flowing out of his eyes, even if he's not crying. And this is the major complaint that the patients complain of when they present to us with ectropion. Is that clear? Okay. Next. So this is another clinical image of a lady, and you can see that there is this reddish firm swelling on the lateral aspect of the lower lid. So based on this image, if you want to conclude, the most common should what come to your mind first. Okay. So this looks like a infectious or an inflammatory swelling, correct? Because it is red, swollen, painful. If asked history, she will let you know. So this is, now one important point, is this hordeolum internum or externum? See this, I'll try to zoom in. It's little poor quality picture, but what I want you to see is, can you see that the pus is pointing out on the outer skin? So I'll explain the difference to you now. So between the difference between the hordeolum internum and externum. So when you take the lid and its cross section, we already discussed this is the hair follicle and this is the meibomian gland. Okay, so if you divide it into anterior and posterior lid margins. So stye is infection of this part. This is stye. Chronic granulomatous inflammation of this is chalazion, and that getting infected is hordeolum internum. This is hordeolum externum. So the pus pointing, when it's very obvious from the outside, okay, it is at the tip of the hair follicle, because this is where the pilosebaceous unit is. Then you have to label it as stye. So acute suppurative inflammation of the follicle of an eyelash a swollen area at the lid margin, a whitish round raised pus point. Can you see this? This is the catch here. So the pus point is very clearly seen at the root of the hair follicle. May be associated with preseptal cellulitis and conjunctival chemosis. Now let us discuss a little bit about this type. See, these are the common conditions that can present to even a GP. Okay, so that is why we need to know this properly. Look at this. This can further spread and involve the free area. Okay, around the eye, there is a lot of free periocular tissue. Okay, periocular loose tissue around which both fluid and pus can collect. Fluid and infection can spread. Understood? So when that happens, the whole area becomes swollen. So that is the condition which is called as preseptal cellulitis. What is this preseptal? What septum are we talking about? So when you talk of this lid, okay, in the beyond the lid is the globe, correct? This is the globe, let us say. So the globe, the front part of the globe and its surrounding structure is separated from the interior of the orbit by the structure called as orbital septum. Okay, so this orbital septum is a important barricade which prevents against the spread of infection. So this is something you must know. So what happens initially to start with, this infection can, all this loose area I was talking about is front of this orbital septum. Understood? So this orbital septum once gets involved, okay, and then the infection penetrates beyond this, it becomes orbital cellulitis. Is it clear? So this orbital cellulitis is nothing but inflammation of the interior aspects of the orbit also. Now, how will you clinically differentiate between these 2 points? Point number 1. If the patient has involvement of the optic nerve, because now orbital cellulitis means it's gone to the interior where optic nerve is there. That will also get inflamed. So RAPD will be present. Secondly, beyond this is where the extraocular muscles get inserted. Correct. So pain on extraocular movements is present in case of orbital cellulitis. So these are the 2 catch points that you should look for when you're trying to diagnose a patient who's come with severe swelling, okay, and they'll have pain, redness around the eye, severe swelling, and they will have fever and general symptoms of, a focus of infection in the body. But to be able to differentiate between this and that, you need to look for these 2 symptoms. Remember, orbital cellulitis is also an ophthalmic emergency and the patient has to be started immediately on IV antibiotics. And remember, this preseptal and orbital cellulitis is common among children because their immunity is usually not fully developed. So, like I said, I'm just trying to touch upon all the infectious conditions around the eye so that, even if there's a change in the question, you'll be able to answer them. Is that clear?